Professor of Psychological Science, and my colleague, Lucy Holmgreen. Lucy.
Psycho-oncologists have taught us that quality cancer care necessarily includes the treatment of social and emotional suffering. Psycho-oncologist Suzanne Chambers has spent her career caring for cancer patients and survivors, studying their experiences, and developing state-of-the-art psycho-oncological treatments. The scope of Dr. Chambers' research program is stunning, ranging from granular studies on the intricacies of living with cancer to 30,000-foot views of global trends in psycho-oncological care. Chambers is a registered nurse and earned her PhD from Griffith University in Queensland, Australia. In 2012, she earned a selective Australian Research Council Future Fellowship, and in 2018 became an Officer of the Order of Australia in recognition of her service in medical research. Dr. Chambers currently serves as Dean of the Faculty of Health at the University of Technology, Sydney, and leads the Centre for Research Excellence in Prostate Cancer Survivorship at Australia's National Health and Medical Research Council. Dr. Chambers' contributions are essential to Nobel Conference 56. Her years of practice and prolific research program have earned her a deep and nuanced understanding of the human experiences of cancer. Chambers' area of research expertise, however, have ventured far beyond individual experiences of cancer and into areas such as geographic disparities in cancer care, the macroeconomics of cancer care, and the politics of cancer funding. Finally, she studies ways to ensure that new knowledge in how best to care for human beings makes it from the lab to the clinic. Dr. Chambers' work is thus situated precisely at the intersection of hope, equity, and access. Please join me in welcoming Dr. Suzanne Chambers.
Hello, my name is Suzanne Chambers and I'm so delighted to be here today. Thank you to the conference organising committee for inviting me to be part of this event, and I'd like to particularly acknowledge Lisa Heidke and Lucy Holmgreen for their support in my participation. I am so appreciative to be part of such an august event with a 50-year heritage, and it's important to acknowledge the long tradition of Gustavus Adolphus College in sharing knowledge for the betterment not just of their own community, but indeed nationally, and one would argue globally. As is traditional in my country, I wish to acknowledge the traditional owners of this land. So I acknowledge the Gamaragal people of the Eora Nation, upon whose ancestral lands this presentation is being recorded. I would like to pay my respects to elders both past and present, and acknowledge them as the traditional custodians of knowledge for this land. I started my professional career actually as a registered nurse working in critical care nursing, and then over time I began to study psychology and working in community cancer support and cancer control. And that led me to the discipline of psycho-oncology, which has led me here to you today through the research and practice that I've done over those many years. So I've had a varied career, and I tend to take a practical application of knowledge, really wanting to know what is it that we need to know so that we can improve things for people with cancer. As you know, I come from Australia. I currently live in Sydney, the most populous city in the most populous state in Australia. Where I hail from is actually Queensland, and my family came from a small country town in the southwest called Mangalala, which currently has a population of about 140, so a very tiny West Country town. And so that has influenced, I think, also the way I think about things, because I'm always trying to reflect on, if we're going to do this to help people with cancer, how is that going to work for people in the bush? As I talk to you today about the experience of cancer patients and their families and how this intersects with the theme of this conference, which is cancer and biotechnology, I'll be weaving into that story some of my experiences as a practitioner, as well as my research, and as well as some of my personal experience, because I think what we all find in this area is that all of those things contribute to your work and contribute to your perspective. As I'm doing so, I expect that some of you will also have had some personal as well as professional experience with cancer, and I want to pay respect to that and hope that my reflections will be helpful to you. My topic today is a dialogue about the care of the patient, and of course this sits within the theme of this meeting about cancer in the age of biotechnology. My aim then is to, as best I can remotely, start with you a conversation about the patient experience and how this sits within biomedical and technological advances. Perhaps the best way that I can do this is by connecting the history of cancer and how biomedical advances have driven the cancer control agenda, the community's response then to this, and of course within that we need to consider the individual's response, and then move on to discuss the challenges we face today. Surgical approaches for cancer treatment advanced after the 1840s when anaesthesia had been developed. And then we had early chemotherapy drug development and radiation therapy, which emerged from the 1900s. These really changed the way we managed cancer. Now, research into more effective cancer treatments then again really escalated in the US when Nixon had his war against cancer with the signing of the National Cancer Act in 1971. Interestingly though, it wasn't until the 1980s that psycho-oncology as a discipline really came onto the scene. In fact, it was in 1984 that Dr. Jimmy Holland from the Memorial Sloan Kettering Centre founded the International Psycho-Oncology Society to improve the care of cancer patients and their families globally by promoting the science of psychosocial and behavioural oncology. And in 1989, the first handbook of psycho-oncology, edited by Jimmy Holland and by Roland, was published. Coincidentally, if I link back to my professional career, it was in 1989 that I moved out of working in an acute care setting to working in the community in cancer control. My work was about developing support programs on the ground for people with cancer and their families. It was a new area of work for me, and it was often bewildering to know what was the best thing to do. So when I came across the Handbook of Psycho-Oncology, it was like a lifeline and really changed my approach to what I was doing. It made me reflect more deeply on the programs and initiatives that we were conducting to support people with cancer and their families, and to really think about, aside from my intuition, what is the actual evidence I have that this will definitely be helpful for people, and what would be the measurable outcomes that one could get from this intervention so that you could know that you really were doing something that was worthwhile and that was truly helping people in an objectively measurable way. Now, if we think about this from the point of view of what happens in the community and what's happening technologically in biomedical advances, the focus very much was on curing the cancer. And of course, that makes sense. Everyone who has cancer wants their cancer to be cured. But the side of care that was really getting less attention was this side of how do we look after the holistic needs of patients and how do we look after the emotional side of things for patients and their families. And what I think is interesting to note is that while the healthcare side of things was really focusing on cure, the focus on care was very much coming out of the community. And so I'd just like to run you through some examples of that. In 1952, Therese Lasser founded the Reach to Recovery Peer Support Program for Women with Breast Cancer. This was a program that started in the US and went global under the auspices of the UICC, the International Union for Cancer Control. It was an interesting time when you think back. That was when radical mastectomy was the standard treatment for breast cancer. This was a very disfiguring treatment and had huge effects on women in terms of lymphedema, limited arm movement. And these were the sides of treatment that was really not being taken into full consideration at that time. Therese Lasser, who experienced a mastectomy, wanted to do something about that in a very practical way. And so she started up a program where women who had been treated for breast cancer went out and visited other women newly treated to give them emotional support, to show them that life could be good again, to help them even with their physical recovery, with their arm movements, and to help them manage all those cosmetic effects of the breast cancer treatment. So that was a very early start to cancer support, and it came from someone who had had the experience of cancer themselves. In In the 1970s and the 1980s, we had laryngectomy societies, stoma associations formed, Canteen looking after teenagers with cancer, Cancer Patients AIDS Association in India, many movements that were happening. In the 1990s, we had grassroots prostate cancer survivorship movements arising in the US and in Australia, Us Too, Prostate Cancer Foundation of Australia and America, Gilda's Club, the Wellness Community, Breast Cancer Network Australia, and many more still emerging. In 1986, the National Coalition for Cancer Survivorship was founded in the US by cancer survivors to advocate for all patients affected by cancer. Now, this group defines survivorship as extending from the time of diagnosis and for the balance of life. And this is a definition that was expanded later to include family, friends, and caregivers, and remains the most widely accepted definition of survivorship today. In 1996, a professionally led NIH National Cancer Institute First Office of Cancer Survivorship was formed. This was 10 years after the coalition had formed through consumers and 50 years after Therese Lasser. So you can see that there is this kind of lag between the community responding more immediately to the psychosocial and broader needs of people affected by cancer, and then health professional responses often coming after that. So these almost occur like two parallel movements that intersect at different times. And of course, the future for us, I think, is really getting those two movements to move more closely together, where the power of them will be much greater if they're able to do that. Now, many of you may know that in the late 80s, early 90s, prostate cancer incidence really escalated with the introduction of the PSA test, which was able to detect abnormalities occurring in this area of the body early for men and suggest that there might be a cancer there. Before that time, the early detection of prostate cancer was really just not possible. So that's an example, I guess, a good example of biomedical technology having an immediate impact on the cancer experience. But at least in my country, there was quite a lag between how supportive care responded to that. So lots of men were being diagnosed, services weren't there for them, and so independently across Australia, grassroots support group movements were just popping up across the country where men were saying, I'm alone, I have no support, I'm feeling in despair, there must be something we can do about it. Over time, these groups took on an advocacy role as well, where they were working to increase attention for prostate cancer, raise awareness, and to improve services. And so there's been huge shifts over time in what we've been able to do in prostate cancer support and survivorship care as a result of the activities of these groups. The sort of research I've been involved in with these groups has involved evaluating the programs, evaluating the experiences of the group leaders, recording the history of the support groups so that we really understand how it is that men mobilise themselves and can take control of a situation and contribute positively to the discussion and to the treatment of prostate cancer. And indeed, this continues today. And I'm very fortunate to have a close relationship with the Prostate Cancer Foundation of Australia and their support groups and continue in this work. And indeed, whenever we're developing new programs or new research programs, we always involve what we call cancer consumers. Not everybody likes that term. We always involve the consumers in this work, and they have been invaluable in assisting us to make sure that the services that we provide are really well targeted and guided by not just research, but also guided by the personal experience of the men and what they have to say and what their partners and family have to say as well. I mentioned earlier that there was work in breast cancer support that also started in the community, that was started in 1952 by Therese Lasser in the US. And I want to talk for a little bit about that work and how that extended, in fact, to my country, to Australia. At the time, this would have been in the 1990s, I was working at, it was called Queensland Cancer Fund there, now called Cancer Council of Queensland. And part of my job became to look after what we called the Breast Cancer Support Service, which was really the Australian version of Reach to Recovery International. So we had all these volunteers who were wonderful women who had themselves previously experienced breast cancer. They underwent a training program to assist them for the role, and then they would visit thousands of women over the years who'd been diagnosed with breast cancer to offer them support with their breast prostheses, with their exercises, with how to get back into life again, every aspect of their recovery. This was amazing work, and when you think of all the volunteer time that went into this, the huge contribution that these cancer survivors were making to their community is really something to pay attention to. While I was doing that, though, it was brought to my attention by some of our volunteers that we weren't really paying the right focus for young women with breast cancer. And so women came to tell me as the health professional, the programs you're doing are great, Suzanne, but we sit in there, we're young, we feel like they're not targeting our concerns, we feel like we're even more isolated and alone in many ways. We want something that's specifically just for us. So that led me to do a number of research projects working with those young women. And the reason why I used a research approach was because I wanted to make sure that I really did understand their concerns and that I really was planning a response to that to help them that was really well targeted. So this wasn't something I was going to do on the fly. The very first project that we did was to work with a whole large group of these young women to say, how do we define a young woman with breast cancer? What does that mean? Is that a woman in her 20s? Is it a woman in her 40s? And we let them work with us in a qualitative research design to define what does young mean in the context of breast cancer. So what was interesting about that was that the definition that these young women came up really wasn't about how old you were. It was about what was going on in your life. Did you have young children? Were you establishing a relationship? Were you hoping that you might have young children or have children? Was this in the future for you? And that was a really quite radical way of looking at what it means to be young and to have cancer that was moving away from a more medical type of approach. Out of that, we developed a program to support young women called the Young Women's Network, where we were organising events for them to get together, where we would provide some psychoeducation and coping information, but largely getting them an opportunity to get together. And I can tell you I ran these in locations across the state where country women would get in a bus and travel for hours to get there and just talk about what a difference it made to them to get in a room with other young women with breast cancer and to be able to finally feel that they really weren't alone. The interesting point of this from a personal point of view is that while I was very involved in that program, and in fact it ended up becoming a national program at one point in Australia where we were having national conferences for young women with breast cancer, and I was very much in touch with people in the US at the time who were developing similar programs, and we were sharing resources and sharing information, was that some time after this, in fact, my younger sister was diagnosed with breast cancer at the age of 33. And I think it's an interesting reflection for us to make as health professionals about what that is like when you do this for your work and you have a professional approach to it and a knowledge base, and it is quite a different experience when it comes to your family in that really close way. One morning when we were sitting having a cup of coffee, and she said to me, you know, it's really isolating being young with breast cancer because when I go to the clinic, everybody's older than me and I just don't feel like they know what to do with a young woman with breast cancer. And I said, well, I know a little bit about that, Meredith. And so we were able to have a conversation about the research that I'd done, which she found really resonated very deeply with what her experience was. Where this story is going is that what Meredith in fact did was established her own organisation of support and advocacy for young women with breast cancer called Amazon Heart. And she did this with her partner, who's now her wife, Megan. This formed into a national movement, Amazon Heart. The sorts of events that they did were threefold really. They were raising money to support breast cancer causes. They were doing advocacy to promote the needs of women with breast cancer, but they were also providing a kind of adventure growth experience for women with breast cancer to help them in a peer support environment try and make sense of their disease. Just a couple of years ago, I was fortunate enough to be in Nepal for a cancer meeting, and I was able to see firsthand the work of the Nepal Cancer Relief Society, which was really quite amazing. This is a country that has still got a developing health system. And much of that is actually built on the work of volunteers who form civil societies and fundraise to support that. I was able to visit the Bhaktapur Cancer Hospital, which was really supported by the Nepal Cancer Relief Society, meet wonderful doctors and nurses who are doing amazing work to support often very needy people in their community, and in conditions and with equipment that much of which you just wouldn't see in this country. I was particularly taken at the time by the work of a ophthalmic oncologist. Her name is Poonima, who is treating children with retinoblastoma. Some of you may know retinoblastoma is a tumour that occurs in the eyes of children and often results in the removal of that eye, and that has cosmetic effects for these children. Poonima is doing this work in Kathmandu, looking after these children, but didn't have the resources to provide custom-made prosthetic eyes for these children. So I was able to say to her and the Nepal Cancer Relief Society, how would it work if we were able to raise money in Australia to buy prosthetic eyes? And I remember Poonima saying, really, would Australians do that? And I said, oh, I'm absolutely certain they would love to do this. So I came back to Australia and we set ourselves up a non-government organisation, just a tiny one called OPENEYES Global. And now what we do is we raise funds. It only costs Australian $150 to provide a custom-made prosthetic eye for a child who's been treated for retinoblastoma and has had their eye removed. And once that happens, that child looks the same as they did before they had that eye removed. And that is hugely important, of course, for their family, for the child's development, for acceptance, and as Poonima says, being able to go through life without judgment. And I guess I would like to think that all of us in any way we can, whether it's the way we direct our research or the way we respond to the communities around us, are able to make a difference in this way. In reflection on the theme of this conference about biotechnology and thinking about technology in general and cancer, is to not make assumptions about what is needed to make a real difference, and that's being open to what you see in the community. It's a quite small investment that we can make in Nepal, for example, to provide beautifully crafted, customised prosthetic eyes for these children. It requires technology, it requires skills. That community has developed those skills. They just needed a little bit of help to be able to pay for the product so that they can deliver it. And that does perhaps lead us to reflection on the broader issues of biotechnology, personalised medicine and equity in health, and about what we come to expect in a developed health system compared to the struggles that are happening in the developing world about what they need to make a difference. But even within our own communities, there are inequities where when we're going to be developing major biomedical advances that will make perhaps a real difference for some who won't get access to those. What is it about our health systems that perhaps at times might block access? And do we consider that when we're advancing technologies and treatments in cancer? I think that's a question for us to reflect upon. The diagnosis of cancer is a major life stress for the person who's diagnosed, for their family, for their friends, for everyone that is close to them. We all know that. It makes sense to us. But if we try and delve into that from a theoretical point of view, why would that be so? And I spent years working with people with cancer trying to figure out the best way that I could discuss this with people who actually have cancer that made sense to them and allowed them to make some sense of all the confusing and difficult emotions and feelings that they were having that perhaps were very new to them and perhaps made them feel a sense of who am I now? When you think about a diagnosis of cancer, it's a major threat. It's a threat to people really, I think, on three key levels. The first, of course, is that it's a threat to survival. When a person is diagnosed with cancer, they're immediately thinking, am I going to survive this? That's often the first question that is on their mind, and trying to understand what information they're given about what their cancer means and what their outcome is likely to be. So it's a threat to survival. The second part of this is that it's a threat to the sense of self. We take for granted what we think about ourselves in terms of how we look, what our capacities are, what we can do, and what we think our life is going to be like from a work point of view, from our fitness, from every aspect of our life. But when you're diagnosed with cancer, you can start to question that. Am I going to look the same? Am I going to feel the same? Am I going to be able to do the things I did before? And if not, for how long is this going to go on for? And so the sense of self can be very deeply affected. And obviously that's more so in some cancers than in others. And then the third threat is the threat to relationships. Will I still be lovable? Will the people around me be okay? Will my work relationships be the same? Will people treat me differently? And people with cancer will often talk about a sense of feeling set apart initially and feeling alone. These are very difficult thoughts and feelings and emotions to have. When I'm working with people with cancer, I often will discuss that with them just to help them put kind of like a framework or a map onto what their experience is to try and make some sense of it. And I will always talk to them using really the stress and coping framework, which most of you, or many of you, the psychologists in the room anyway, will know about, which says that when you get a major life threat, you'll have a thought reaction to it, you'll have ways that you think about it, you'll have emotions that you have about that, and you'll have actions that you take, and you'll have physiological responses to stress. And the usefulness of that framework, I think, in working with people with cancer is that it provides the person with different points that they can work on, strategies that they can use for each of those points that can help them to cope with the situation they're in. Because we know that it's very common for people to feel shocked, to feel afraid, to feel sad, to experience anxiety and depression. These are common things that happen. In a general sense, if you look at what's the extent or the prevalence of depression, anxiety, high psychological distress in cancer, the general estimate that you'll often get is around 25 to 30% of people having ongoing significant distress. And this, of course, varies by cancer type. Some types of cancers have different treatment characteristics. If your cancer is more advanced, that's going to be more difficult to deal with than if you have a localized cancer. What is your age? If you're young, it's very threatening to be diagnosed with cancer because you don't expect it. Not that it's not really awful being diagnosed with cancer when you're older either, but we know that age plays into people's responses. If you're poor, if you don't have many financial resources, then it's harder for you to get the treatment that you need and to get all the resources that you'll need to get through this experience. If you have lower levels of education, it can be harder because it's harder to understand what you're being told. The information that's given to you is very information heavy, and it can be hard to even know what the doctors are talking about at times. If you have other stresses going on in your life and other illnesses, so comorbidities, that also increases the likelihood that you're going to have more psychological distress if you're diagnosed with cancer. So we have many descriptive studies across many cancer sites that describe what the experience of cancer is like, what the problems are that people are experiencing. We also know how to detect this. Jimmy Holland, who I've mentioned before, pioneered the idea of distress screening, detecting distress early, and in fact at Memorial Sloan Kettering they developed a distress thermometer that's used widely. Single question that can give you a good idea. It has a threshold that you use so that you know whether or not you should be thinking that the person that you're working with is likely to have clinically significant anxiety, depression or distress. So we know that distress happens, we know how to detect it, and we also know how to treat it. There have been many studies, predominantly in breast cancer, but other areas as well, and soon I'll talk a bit more about my prostate cancer research. But we know that there are many approaches, often with a cognitive behavioural approach, a problem-solving approach, a stress management approach. These things that are actions that we can take as health professionals. We can develop these programs and we can deliver them to people at need. And there are many of those around, and you'll be familiar with much of that, I imagine, and much of the literature. The big problem that we tend to get into is when we want to take the knowledge that we have and we want to implement it into practice, so that it kind of becomes a situation of where we're saying we know that the distress is there and that there are unmet needs for support. We know what we could do that might make a measurable difference in people's lives, but not everybody's getting access to it, and that is the key problem. So to give you an example of I guess what my research has been in psycho-oncology and what my major focus has been, I'm going to talk to you a bit about prostate cancer research in psychosocial care, mostly to give an example of how it can evolve and build over time. But I would say to you that while I am mostly known for my prostate cancer research, I've certainly done work on lung cancer and stigma, and I've talked about my work with women with breast cancer, and I've done work with people with brain tumours as well. So I have a broad knowledge, but it would be the case that the area where I've done the most work has been prostate cancer. And the reason for that really is just that when I was working in the community in the 90s, it was just so clear that nobody was doing this work and there was a need. And I had men coming to me and saying, Suzanne, we'd like you to do something about this. And I was honoured to be asked and happy to do that. So in the early years, really in the late 90s and early 2000s, we were really at the stage of just doing basic descriptive research, and we were a good 10 years at least behind breast cancer in that, I think, because the area, for historical reasons largely, and partly because not having a high-profile advocacy movement, it really had been left to the wayside. And it was important for me as a practitioner to be doing that because I wanted to really make sure I understood the problem well, and that anything I did was going to help and not harm. And I think it's always important as practitioner researchers that we remember we can't assume that everything we do will be helpful. So I started doing research on really measuring the psychological distress that men experience, decision regret, a whole range of outcomes, so that I could go back to the urologists and the radiation oncologists that I work with and saying, you guys are great, you're doing amazing work in treating these patients, but these are the problems that they are experiencing over time. And I was very fortunate to be working with a very vibrant urological community in Queensland at the time who were really interested in what I was finding and interested in doing something about it. And that close collaboration remains to this day. So I was publishing work showing that a significant proportion of men were experiencing distress, and this was a surprise to some people who assumed because men weren't talking about it that they weren't distressed, but in fact they were. And that was getting it on the agenda straight off. The next thing that I did was worked, in fact, with Jimmy Holland on doing very detailed validation work for measuring distress with the brief distress thermometer in men with prostate cancer, and we did that work together so that we were able to say, this is the amount of distress there is, and this is how you detect it. Moving on from that, we were able to do a number of randomised controlled trials where we were looking at various types of interventions, again, some more descriptive work, so that we were able to say, this is the preferred source of support for men, this is where they want to get support from, and we were trialling different types of support, nurse-delivered support programs, peer-delivered support programs, and some delivered by psychologists. That enabled us to come up with a body of knowledge from which it was possible for people out in health services and in the community to develop their own programs that would work with their own context to help the men that they were with. We then were doing additional work looking at what are the barriers for men in help seeking and what are the characteristics that we need to be thinking about when we're supporting men with prostate cancer. And we in fact developed a specific scale called the Masculinity and Chronic Disease Inventory so that we could measure different masculine values and beliefs and look at which of these predicted help seeking. The point of that is so that if you know that these are the factors that predict help seeking, you know what you need to adjust if you want to get men who need help to reach out for that help. There's a lot of work going on in this area by a number of people and very incredibly clever scholars that I work with in different places. I'm thinking of John Olive at University of British Columbia, who's doing a lot of work on men-centred care. And there are people like John, of course, in Australia as well, and really trying to shift the conversation about men's health to saying we're not going to be trying to take something that's worked in breast cancer and we'll just put it in prostate cancer, but we want to develop supportive care innovation for men with prostate cancer that is tailored to what we call men-centered care, delivering help to men in the way that they want to receive it. So personal work that I've done there includes a book called Facing the Tiger that I published quite some years ago. I think it was 2013, and just got a new edition of that coming out at the end of this year. And what Facing the Tiger is, it's a survivorship guide for men with prostate cancer, their partners and their families. And it's taking evidence-based information about how you cope with psychological challenges, how you make decisions, how you build meaning in your life, how you move forward, how you make a survivorship plan, putting it in language that's normal to men, normal layperson language, and giving personal stories from men who actually have had prostate cancer to show how different men have put this into place. The importance of that idea is that you are supporting men to be able to do this themselves by providing something that is good, solid, evidence-based information that they can take and they can use, and they can share it with their partner and their family and work together as a team to move forward. And I guess that connects to what I have mentioned earlier, which is my main concern about challenges for the future is about implementation. We know lots, we have all this knowledge, and they often call it the valley of death, the gap between knowledge and then it actually getting into action. And some people say it can take 20 years for something to move from the knowledge into action. And clearly that's just too long. We can't wait that long for this. As a result, much of the work I'm doing is now moving into implementation. I'm fortunate that I lead a National Health and Medical Research Council Centre for Research Excellence in Prostate Cancer Survivorship in Australia. That's a federally funded program, and I have collaborators across the country in different universities and even some in the US. We have 10 chief investigators, 10 associate investigators, and about 20 or 30 affiliates with that program. All of us working on different aspects of prostate cancer survivorship and really now all getting to the pointy end where we're trying to make things change. So as a result of that, what we did last year was working again in collaboration with all of that team, but also with all the major medical and nursing societies in Australia that work in the prostate cancer area, as well as all the major consumer groups, including the Prostate Cancer Foundation of Australia. We developed a national position statement on distress screening and referral for psychosocial care for men with prostate cancer. And what was so exciting about that, from my point of view, was that we got sign-on from every major group in the country that we asked. We're all happy to get behind this. We developed a monograph to go with it so that we're not just saying, you should do this, we're saying you should do this and this is how you could do it. We've been developing educational materials to help skill health professionals up for that. In fact, we have an open access online program for distress screening and prostate cancer through my university, University of Technology, Sydney, that we have developed with support from the Prostate Cancer Foundation of Australia. We've tested it out with prostate cancer specialist nurses, and now anyone in the world can log on and can access that training program. And there's more of that training work coming through as we go. Another example of this pushing into advocacy and implementation and translation is that we started a project last year. This was led by my colleague, Jeff Dunn, who is a chief investigator in the Centre for Research Excellence. And that project is developing a framework for prostate cancer survivorship. This was an amazing program that we all contributed to. We used a policy Delphi strategy for that. We had an expert panel of 47 from across Australia and New Zealand who worked with us on developing that framework. And importantly, and differentiating this from previous such efforts, a third of the panel were consumers. So we had researchers, academics, health professionals working in a team with men who've had prostate cancer themselves. And so, again, I mentioned earlier that often the community work and the health professional work can be in parallel but doesn't always intersect. What we were doing was making sure we had the intersection at the start, and we've been able to publish that work now in the British Journal of Urology International. The quantum of work that I have been involved in has been a collection of people who are mission focused in the work that they want to do and who share a common vision, a common belief that if we all work together, we can make a difference in cancer control. We can make a difference in cancer control in our own communities, in our country, and indeed do so globally. For all of us, we need to always remember that it's a collective effort, and that's where speaking to people in this audience who are perhaps early career researchers, you're our leaders for the future. We really need you. And so please be involved in our work, ask questions and step forward, because we need to pass the torch to you and look forward to seeing the new insights and the new ways that you will have looking at what are the issues for people with cancer and what are the issues for people with cancer in the age of biotechnology, and how are you going to help meet those challenges ahead. I think we would have more luck at beating this gap from knowledge into translation if we could get the consumer voice more involved. Professor Trish Greenhalgh has talked about biases against the consumer voice. She describes that there is a low status of experience in the hierarchy of evidence, a limited patient input in general to research design, insufficient attention being paid to power imbalances that suppress the patient's voice, and a focus on people who seek and obtain care rather than those who do not seek or cannot access care. So as biotechnology hastens the arrival of personalised medicine, all of which will have their own specific issues in terms of the patient experience and the patient outcomes, not to mention, of course, access and equity, we need to ask ourselves the question, how do we ensure that the patient voice is not lost in all of this? A recent review by Palumbo concluded that clinical practice guidelines are built appropriately upon the highest level scientific evidence available, systematic reviews, meta-analyses, randomised control trials, and expert consensus opinion. But, this is the but side, consumer voice is not the norm in these, and when it is, it's often token. Most organisations involved in clinical practice guideline production do not require consumer input, and as few as 1 in 5 consumer versions of these scientific documents have this included. So how do we not lose the consumer voice? How do we keep the consumer as an active agent in the team in the interests really of better implementation of knowledge and ultimately better outcomes? My talk has focused around cancer and how as a society and as individuals we have faced this challenge. There will be lessons in this for us globally as we confront the terrible toll of COVID-19 and learn to adjust to a changed world. Perhaps the lessons are to remember our resilience, that we do better when we act collectively, and that our core values around equity, respect for life, caring for the vulnerable and compassion for others can guide us. In 1927, Frances Peabody, an American physician who was himself to die of cancer in that very year, wrote on the care of the patient in the Journal of the American Medical Association. His words, "Disease in man is never exactly the same as disease in an experimental animal, for in man the disease at once affects and is affected by what we call the emotional life. Thus, the physician who attempts to take care of a patient while he neglects this factor is as unscientific as the investigator who neglects to control all the conditions that may affect his experiment." So what are we hoping for? What am I hoping for? I think what we need to really be trying to do is to be truly moving from the traditional biomedical view of health and healthcare, where really in many ways the patient is a passive receiver of the service, to something that really is co-produced, where the patient voice is heard and where the patient is working and the patient's family is working collaboratively together with the physician, with the nurse and with the healthcare team. We talk about this a lot. I'm just not sure we truly do this, and I think if we want to change things, if we really want to move forward, the answer lies in that, and this is only going to become even more important in the age of biotechnology, where everything becomes more complex and faster. We've really got to reach back into the patient voice and the community voice and make sure we get that connection right. So for all of you, I leave that there as a discussion point and as the challenge for us as we move forward. Thank you for your attention. It's been so lovely to connect with you all, even though it's been remotely. And I wish you all the best, and I would ask you all to stay safe and well. Thank you.
Hi, Lucy.
Hello, Lisa. Happy to be here.
Lucy Holmgreen, my colleague in the Department of Psychological Sciences. Lucy, I want to do a couple of business items before we turn to our conversation. First of all, a reminder to you all to submit a question to Poll Everywhere. That's pollev.com/Nobel56. And in a minute, Lucy, you'll help me remember we're going to turn to a poll question, which you can also find there. If you prefer to text your question, you can do that at 2233, and again, text the number Nobel56. After Lucy's and my conversation, there will again be Zoom discussions happening, and one of the special offerings for this Zoom discussion is a conversation with the author of Mom's Cancer, Brian Fees. Mom's Cancer is a graphic work that was the reading in common, or is the reading in common this year for our incoming first-year class. And you can find directions on how to get to those Zoom conversations by going to the live stream for this conference. If you're seeing it from Facebook, you need to hop over to the Nobel Conference page or to the Gustavus homepage and enter through that portal, and then you can find those Zoom links on that page. So please do join one of those conversations. So now, turning it over to Lucy. It's so exciting after 2 years of preparing for these discussions to finally be having a little chance to debrief after it. So I'm wondering if you want to offer any initial reactions. If not, I have plenty of things to ask you.
Sure. I just really enjoyed Dr. Chambers' talk. I think she's delightful. I think the thing that really jumps out to me when I listen to her is how she does not seem to be a person who even perceives barriers in her path. She perceives maybe wrinkles or complications, but never barriers. It's like, oh, we need a book for prostate cancer survivors. I guess I better go write that, right? So I just love listening to her talk about how she overcomes these things.
I think it all has to do with not having that first cup of coffee in the morning. That's what keeps you writing the book, right?
Yes, that was fascinating to hear as well in the podcast. Absolutely.
So early on in her talk, she gave a definition of survivorship. And it's clear that that's a term of art within this field. So can you talk about it a little bit? And why is it important to define what that word means? Shouldn't it just be obvious?
That's a great question. I think that it's important to capture the idea that cancer is an evolving stressor. So it's not just an event that happens to people, it's something that evolves over time. So the stress you feel when you first are diagnosed might differ from the stress you feel, say, a month after diagnosis. I think that extending survivorship to the end of life also acknowledges the fact that whether or not your cancer sort of goes away or goes into remission, you may still feel effects of the stressors of cancer well beyond when that might happen. So important to encompass the entire patient experience, whereas perhaps from a biomedical model, once someone's cancer is sort of eradicated biologically, we might sort of consider them done. But the definition of survivorship, extending well beyond that, I think really acknowledges that the effect of cancer doesn't just stop when the cancer leaves your body, if that's what happens.
And one of the things that has been really impressed upon me during preparing for this conference is the fact that the good news is more and more people will find themselves in exactly that situation as more and more people are able to survive particular cancers.
Yeah, absolutely.
So one of the things that she's really focusing on in this talk, as I heard it, is that gap between, care for the tumor, if you will, and care for the patient. And Historically, she suggests that care for the patient has really been happening in the community, whereas obviously care for the tumor has happened in the clinic. Why is that gap so intractable?
It's a fantastic question, and one that lots of professionals from different disciplines, I think, have been trying to address for some time now. It gets to, I think, basic ideas about how we define health and wellness. What do we mean by that? Do we mean disease-free, or lesion-free when we say someone is healthy? Or do we mean something much more holistic and encompassing a broader look at how they function as a human being? I think it gets to siloing and how in our disciplines we tend to stay in our lane and not necessarily consider the other areas that might affect our area of research. I think Dr. Chambers also touched on one of the problems when she talked about bias against patient experience as a sort of valid strain of evidence when we do RCTs, for example, or randomized controlled trials. So yeah, I think it's about getting different kinds of professionals to talk to each other more. For example, at a conference where you get a bunch of people from different fields and you get them in the same room or virtually in the same room and you have them start talking to each other.
Yeah, we should do that. That'd be really cool.
I think it would be a fantastic idea, honestly.
So yes, I was thinking about Shanita Hughes-Halbert's work on social determinants of health and the ways in which that certainly we're starting to see that make its way into the clinic, where when I get intake for, whatever, my annual exam or something like that, I'm being asked more questions than when I was 30. Not only because I'm 60, but because healthcare has changed. And I also think about the exciting work we'll hear from Bisan Al-Azakani this afternoon, in which I think the kind of knowledge-based creation that they're working on is saying, how can we make meaningful use of that patient experience? Because it's obviously so vitally important. Lucy, yes. Go ahead, please.
Oh, I was just going to say, I think some of the discussion that came up yesterday about the electronic medical record gets to that question of how do we make this data or these data useful. And I think that actually getting people from one profession to acknowledge the importance of a variable that sort of comes out of a different profession can be difficult. So even once you have the data to show, for example, this psychosocial variable is incredibly important to this medical outcome, it can be incredibly difficult to get physicians on board with that, for example. And that's not about individual physicians. That's about our system of training and how we I think, again, silo our healthcare.
Mm-hmm. One of my favorite weird examples in that regard is the fact that dentistry is entirely separate from all of the other parts of your body, almost as if your teeth are far away from your brain, for instance, such that dental caries could never possibly have any effect on your, brain health. I would love to change the subject away from my knowledge of dentistry toward the poll question, which again, pollev.com//Nobel56. And the question is, after hearing this lecture about psycho-oncology and its approach, which statement below do you identify with most? And again, there isn't I identify with all of these option on poll everywhere the way we've used it, but looks like there's quite a lot of agreement on this one. Lucy, what do you make of the results of this poll? I think you can see it.
Yes, I can, and I am happy to see that it would appear that most folks seem on board with the idea that that treating emotional and social needs of individuals with cancer is important. And I'm not sure we would have seen the same results to this poll had we administered it in the 1950s, for example. I don't know that you would have seen this exact same distribution of results. I'm interested to watch that caregiver question sort of wobble here a little bit, and that's interesting.
Right. Yes, it is. Say more about that.
Yeah, I think there's growing awareness of the importance of care for caregivers, especially as folks find themselves caring for both aging parents and young children, for example, as the boomer generation ages. I think there's growing awareness that caregiving is itself an incredibly stressful experience, and that requires its own kind of care. So I think there's an analogy there with caring for someone with cancer, right? If you're doing caregiving, that's a chronic stressor. So I like that Dr. Chambers' research, for example, pulls in partners and family to an extent that just doesn't happen as much in a lot of other research areas.
Right, right. Indeed, that was one of the things that I found really interesting about toward the end of her work, toward the end of her talk. She was emphasizing the fact that as we move in a positive direction, and I think you're right, she's assuming we will, she's not saying, let's abandon those community support networks and medicalize everything. I don't hear that at all. Do you have thoughts about the kind of vision that she's presenting us with, in which care, organizations are at the table?
Yeah, I think it's all about integration and interdisciplinarity and valuing patient experience as an important line of evidence. So it's about getting everyone at the table, and I think Dr. Chambers, in all of her work, has really embraced that framework. She came out of that, right? Her work sort of began from working in the community to care for cancer survivors. And I think she has really carried that perspective through all of her work going forward.
Mm-hmm. And on that, maybe a related point, I thought one of the most powerful observations that she makes is that you can't just take what worked for breast cancer and, add a different ribbon and make it be about prostate cancer. What is the importance of her observation that, for instance, men manifest stress in ways that were invisible to, designed experiments or studies?
Yes. So I think that this gets at something she said. I don't remember if it was her talk now or the podcast, but she talks about RCTs being these blunt instruments, these averages. RCTs meaning randomized controlled trials. So these are kind of the gold standard for intervention research. That is things like drug trials or finding out if a new therapy is helpful. And I think it was Dr. June who touched on this, we exclude all kinds of people from those trials to try to make them stronger in their ability to draw causal conclusions about the intervention itself. We try to get a sort of pool of people who just have the one thing in common. But when we study an intervention, it's only as good, first of all, as our ability to get people to do the intervention. So if we were to take an intervention for breast cancer survivors and just sort of plug it into a study of prostate cancer survivors, likely what we would find is that the intervention itself might be helpful if you could get people to do it. So one of Dr. Chambers' studies was of a web-based intervention that provided psychosocial support to individuals with prostate cancer. And what she found involved the analysis, two different kinds of analyses that are really important in this kind of research. So you have to look at both what's called an intent to treat analysis, which means if you look at everybody who started the trial in whatever condition they were in, the experimental or the control, you look at their results down the line, that's different than looking at just the people who actually completed the intervention. So if you can imagine a drug, for example, for diabetes that's incredibly effective but also has massively unpleasant side effects, it would be important to know both that most of the people who started taking that diabetes drug didn't end up still taking it by the end of the trial, right? You have to know that about your drug. It would also be very important to know that if they did keep taking it, their A1C or their diabetes was much better managed at the end of the trial, right? So you have to know, is this a palatable intervention? And does it work if you can actually get people to engage in it? And I think that's really key to understanding her comments about we can't just plug this intervention in for this other group necessarily.
Excellent, excellent point. And it looks like, unfortunately, we have run down the clock. I wanted to say we will begin the 12 o'clock hour. Again, if you choose not to go to a Zoom discussion, you can find last night's Nobel concert, a beautiful half-hour concert we'll be playing immediately now. I also wanted to put in a plug for the bookmark, the Gustavus bookmark, which has a number of cancer-related works available, both fiction and nonfiction works available, and you can order those. If you go to the Nobel Conference page, navigate to Learn More About Cancer, and from there navigate to Cancer Stories. You'll find that whole list. Also know that we do have a little bit of Nobel merch, including coffee mugs and also the usual Nobel t-shirts, which you can order from the